Good afternoon. My name is Madden Brewster. I'm a postdoctoral fellow at the University of British Columbia, Okanagan. Before I begin, I'd like to acknowledge that the University of British Columbia, Okanagan is situated on the traditional, ancestral, and unceded territories of the Syilx Okanagan peoples. And I'd also like to acknowledge that most of the work that I'll present today took place on Sinixt, Ktunaxa, and Lil'wat Nation territory. Now, today I'll be presenting a bit of data from an ongoing longitudinal study, which is conducted in partnership with the British Columbia Wildfire Service, called the Cardiorespiratory Effects of Wildfire Suppression, or CREWS study. Quick presentation outline. I'll give you a really brief background, then we'll get right into an overview of the CREWS study, followed by a few results, mostly across a single shift, so more in that acute space, but I'll touch on some one-year findings as well, and then finish up with some future directions. It's funny that this photo in kind of a different way was brought up, but I probably don't need to tell you all this, but wildfire has been around for many years. It's part of our natural ecosystem, but as many of you know, wildfire seasons are getting more severe and prolonged. And this is showing area burned in Canada, denoted by the red perimeters in 1990 versus 2023. This is largely due to a changing climate. It's getting hotter. That's overall increasing fuel availability, but also historical land management practices have affected fuel loading. And of course, urban development has really increased the incidence of large fire disasters and its severity for humans. Now, at the front lines fighting these fires are wildland firefighters. And on the fire line, wildland firefighters work incredibly long and arduous days with a number of environmental stressors. They've got pollutant exposures from smoke. Also, all of these photos are from my own experience on the fire line. But they've got pollutant exposures from smoke, as well as regular engine exhaust, dust, soil, and ash. All of those contain harmful components. And at times, due to proximity to the actual fire, they're getting hot. And even if they're not close to the fire, they're working 12 to 14-hour shifts in the middle of summer doing physically demanding tasks. So they're also exposed to quite the thermal stress. Now, this combination of stressors is particularly burdensome on the cardiorespiratory system. And a lot of studies have really focused on directly investigating the health effects of wildfire suppression, primarily focusing on lung health due to the inhalation of exposures without general use of respiratory protective equipment. Most of those studies really only look acutely, so either across a single shift or even across a single season, but very few have touched beyond that point. So because of that limited long-term data examining wildland firefighter health, for over a year before the study began, we collaborated with the BC Wildfire Service as key partners and knowledge users of this work to really refine project aims addressing both chronic and acute gaps in cardiorespiratory health of wildland firefighters, while also examining mechanisms which might eventually allow us sort of new intervention avenues. Now, to give you an idea of the extent of this research project, this is an ambitious longitudinal study which follows the same individuals across 3 consecutive seasons. Our experimental overview of this study was recently published in Frontiers in Public Health. And we began data collection last spring, so in 2024, showing this time point here. And we recently completed pre-season testing for 2025 as well. And we'll continue into the remainder of these time points through 2025 and into 2026 as well. Now, beyond testing sort of before and after the wildfire seasons and these pre and post-season testing blocks, we also are really using this mid-season testing time point to sort of address novel aims that support current literature about the acute effects of wildfire suppression. So looking more across the shift, for example, or the season, we're going to look across a deployment. Now, we conduct a variety of measures before and after the season for the longitudinal portion of the study, looking at clinical as well as subclinical mechanisms of vascular and respiratory function, which is shown here. However, due to time constraints and feasibility, we're unable to do all of these measures in a mid-season time point, so like before a shift or after a shift, for example. So to address more acute questions, we use more feasible metrics. So in the 2024 season, for example, we assessed pulmonary gas exchange as well as impulse oscillometry across a single wildfire suppression shift, while simultaneously measuring exposure to particulate matter. Now I'm going to focus on the two measures which we used for that mid-season testing, the first one being pulmonary gas exchange. And gas exchange is really how well oxygen from the tiny sacs in our lungs, our alveoli, gets through the alveoli into our capillaries, into our blood, and eventually to our tissues. Now, it can be affected by things like surface area of the alveoli in this membrane, thickness of this membrane as well that the oxygen has to diffuse across, as well as pressure gradients, which drive the movement of oxygen. Now, you can imagine if particulate matter from smoke or other sources travel deep into the airways, they may get lodged in this membrane, effectively taking away the surface area for gas exchange to occur. Now, on the other hand, if particulate matter instigates inflammation in the airways, leading to swelling or even mucus or fluid buildup in that membrane, both the surface area and membrane thickness could be effective, thereby also limiting oxygen's ability to diffuse across that membrane. Now, to measure gas exchange, we measure oxygen in the alveoli, so in the lungs, and oxygen in the blood, and we subtract the two to get what's called the oxygen deficit. The higher that oxygen deficit value is, the more gas exchange is assumed to be impaired. In our study, however, we use a proxy for arterial oxygen, so we don't have to invasively draw arterial blood. Okay, impulse oscillometry, on the other hand, is sort of a growing subclinical measure, which uses sound waves at different frequencies to assess regional differences in airway resistance and reactance, which is essentially elasticity of our airways. And it can distinguish between our entire airways, so all the way from your mouth to the alveoli, as well as the peripheral airways, so just where your alveoli are, for example, or the bronchioles, so close to those gas exchanging regions. Now I'm going to focus on total airway resistance for the sake of this talk. And a change in diameter of the airways will affect its resistance. So for example, when we exercise, we have a natural widening of our airways, increasing the diameter and ultimately lowering resistance. Now, when it's smoky or heavily polluted, our airways tend to constrict, so that diameter gets smaller to really minimize the entry of pollutants, and this increases resistance. Now, if we have an obstruction in the airways, this will also serve to increase resistance. So in 2024, in the middle of the season, we tested 36 young, healthy wildland firefighters from the BC Wildfire Service with an average career length of 5 years for pulmonary gas exchange efficiency and airway resistance. So here I am in the back of a BCWS vehicle conducting that impulse oscillometry measure before as well as after a wildfire suppression shift. And we also measured particulate matter from smoke and ash, as well as soil and dust from personal air sampling equipment that looked something like this on the chest pack of a wildland firefighter. Now, remember that oxygen deficit, which is shown in this yellow box here, is the difference between oxygen in the alveoli, in the lungs, shown in blue, as well as oxygen in the arterial blood here. The higher that oxygen deficit, the greater the impairment in gas exchange, like in this example, where that drastic drop in oxygen in the arterial blood results in a really high oxygen deficit. Now, we saw that across the shift, oxygen deficit increased from pre-shift to post-shift, suggesting a mild impairment in gas exchange. I say mild because most individuals are below this clinical threshold for abnormal gas exchange, which is denoted by an oxygen deficit of 15 millimeters of mercury. Now I want to show you some data looking at that same oxygen deficit value from across the season. So these are those same pre-shift, post-shift variables plotted here. And we see that increased oxygen deficit that occurred across the shift, indicating that impairment in gas exchange is actually sustained across a single season as well. So you don't see a drop, despite the fact that most of these postseason metrics were obtained about 26 days on average since firefighters' last fire line day. So since the last time they were engaged in a typical wildfire suppression shift. Now, this to me suggests that perhaps repeated exposure to the wildfire suppression environment really results in an accumulation of sustained impairment. However, we have to really examine this throughout multiple deployments or multiple shifts to really get a better idea of what this progression truly looks like. So I'm going to bring you back to that acute impairment and gas exchange, so across a single shift again. So this is that same graph that you saw a few slides ago. And remember that we said impaired pulmonary gas exchange really indicates that something is going on in this membrane between the alveoli and capillaries. And it really might be that particulate could be getting lodged in this space or even influencing the properties of this space through secondary effects like inflammation, increased mucus secretion. So our natural question really was to determine if the impairment in pulmonary gas exchange was associated with personal particulate matter exposure that we measured throughout the shift. Now, we found that particulate from wildfire smoke and ash, shown on the left graph here, as well as soil and dust indicated by respiratory crystalline silica on the right here, were not significantly correlated with our change in oxygen deficit. Now, I'm not entirely sold that this means that there's not an association between exposure to particulate and pulmonary gas exchange efficiency, because there are certainly limitations of this design. One of the largest ones being that the study didn't account for things like biological dose. So how much is the exposure measured at the breathing zone from our personal air sampling device actually reflecting the exposure that we see at the level of the lungs, which would be affected by things like respiratory rate. Another thing the study didn't account for is lag time. So is the particulate that we measured that day affecting the gas exchange immediately after, or is it the day before, or an accumulation of several days prior? There are also other exposures like pHs, like Dr. Cherry spoke about before, and mechanisms which we didn't measure in this study and could be something entirely different, which is why we don't see a change or a correlation with our particulate matter exposures. Either way, future studies are warranted to really investigate these mechanisms and their implications, which is something we're hoping to follow up on this season. So now moving on to the results from impulse oscillometry, again focusing on that total airway resistance, which if you remember, would be higher with a constriction or obstruction of the airways. And we know that pollution, especially wildfire smoke, has been shown to constrict or narrow the airways, either through inflammation or other pathways, which would serve to increase resistance. So we hypothesized that we would see an increased resistance across the shift due to their exposure to wildfire smoke and other particulates. However, what we saw was a decrease in resistance, albeit this decrease is quite slight, but ultimately it indicates some sort of dilation or widening of the airways. Now, we thought this might be due to a number of things, one of them being natural variation of airway resistance across the course of a day. So two of my amazing students, Bridie Lemke's and Taylor Graff, ruled this out, finding no difference between morning and evening airway resistance in controlled participants in laboratory. Now, we also considered that passive or active heat stress could be affecting the dilation, given that these wildland firefighters are basically stepping off the line, giving 5 to 10 minutes while they're at the trucks, and then we're testing them right away at the staging area. And what we found is that a significant negative correlation existed between ambient temperature, shown on the x-axis, and change in total airway resistance from pre-shift to post-shift, suggesting at least an association between increased temperature and decreased airway resistance. Now, in the coming season, we're hoping to follow up on this with core temperature measurements as well, not just ambient temperature. So to sort of conclude, I want to finish off with some future directions. So we're, of course, going to continue our longitudinal study into 2026. For our acute studies this year, we're actually hoping to follow up with some of those mechanisms of gas exchange impairment, adding respiratory inflammation measures, as well as respiratory rate to get a better idea of biological dose. And then also adding core temperature to sort of determine its association with airway resistance. Now, we'll also be looking at these variables across an entire deployment, as well as the recovery days, so the days off, to really help to determine the accumulation of some of these measures, as well as the amount of time needed to sufficiently recover, if that even occurs in the several days off that they have before resetting. And then finally, diving into the co-exposure of heat and pollution question, which might really influence the toxicity of these exposures. Hoping to expand this work to other relevant outdoor workers, of which there are many, and are working with groups like the Brinkman Group to examine similar outcomes in tree planters, for example. And then finally, just really hoping that this work gets ultimately directed into different interventions, maybe not previously thought of, especially while looking at mechanisms to ultimately help reduce negative health outcomes in wildland firefighters and other outdoor workers. So a lot to be thankful for, many individuals involved in this work. I won't name them all for the sake of time, but we'll give a special thank you to the BC Wildfire Service crews involved in this study. And I'm guessing we don't have time for questions, but my email's at the top there. Feel free to email me or send a chat to me. Thanks.
All right, if you could thank the speaker.